Welcome, everyone. This is I'm Mary Jo Murphy, and this is our 8th seminar. We've been doing this as of December for 2 years. The title of the seminar is How to Talk to Your Doctor, Empower Yourself Today. I want you to know that the 3 speakers, Dr. Mary Birdsall, Emily Miller, and Dr. Linda Hips, have all been on both sides of this picture. So we aren't necessarily picking on doctors or practitioners. We're just bringing up a topic that comes up all the time. And our goal is to increase the quality of our conversations and our interactions with our practitioners, with our physicians, with our nurse practitioners. So we usually do our in-memory slide, but right now we're having trouble finding it, so we may save that until the end. I also, you should know, of course, what you always do, that this is not a substitute for medical advice. So we will each start by telling a little story, and I'm going to tell mine first really quickly. While we talked about this topic in preparing for this, I had a memory. And sometimes you block things, you don't necessarily bring them up because they were painful. But I remember when I was being measured for the mold that I was supposed to sit on while I was getting my radiation, I was in a very undignified position with my legs spread out, and I was not covered. And I remember there were people walking in and out of the room, and one of them, they were mostly women and my radiation oncologist, but at one point, one of the male technicians walked in, and I remember just being mortified. And I'm sure that he never thought a thing of it, but it was sort of the beginning of me realizing that I was kind of losing my bodily integrity, my dignity, and my modesty, and all the things that happen to all of us. So I think we've all had experiences like that, and I just wanted to share that one because it just recently came back to me. Okay, Emily, you want to?
Yep. Next slide. Welcome, everyone, and thank you, Mary Jo, for a wonderful introduction to the topic we're going to be discussing. So we'll be sharing more stories and our expertise now. My name is Emily Miller. I'm a nurse practitioner. I specialized in women's health, and I've been working with HPV-related issues for the last 3 years. Our topic today spans specialties and is probably something we all have encountered. It's important to be aware of these experiences and to take steps to empower our patients, ourselves, and prevent this from happening in the future. Next slide. So even as a clinician, I've had my own experiences in healthcare of not being heard or respected. Recently, I had my gallbladder taken out, and I was really nervous. This is my first major surgery, and I already met most of the team, but the resident came in, and he was asking me all these questions right before I was going in for the surgery. My name, my date of birth, my medical history, all the prescriptions, everything. And then he goes, "Oh, do you know what surgery you're having today?" And I said, "My gallbladder." And I pointed to the opposite side of my stomach where the gallbladder was. And he just said, "Do you even know why you're here?" And I felt so like I wasn't heard or even acknowledging that, I was scared for going for this surgery. And I think this is going to be reflected in today's discussion and with all our stories of just not being respected or heard. So I'm going to pass it on to Linda for her story. Next slide.
So welcome, everyone. I'm Dr. Linda Hips. I practice in Allentown, Pennsylvania, and I'm an OBGYN with 35 years experience, and the last 25 years specifically GYN only, with an interest in HPV-related diseases. So we hope that we can help you learn how to empower yourself when you see your healthcare provider. I personally, like Emily, also was made to feel that my concerns were stupid. For years, I had abdominal pain, distension, colon and kept telling doctors that I could feel my colon going in the opposite direction. And they looked at me and said I was crazy and that's not the way your colon works. Yes, I know that. I am a physician. To make a long story short, I wound up having a flipped colon due to the lack of congenital ligaments on my left side. So we're here today to help you ask your questions, not to be embarrassed, and more importantly, to empower yourselves at the same time. And I think we'll go on to our next speaker.
Hi.
Mary Birdsall.
Hi, my name's Mary Birdsall, and 2 years ago I was a busy gynecologist running a large IVF group. I was 59, married to my family physician husband, had been for 34 years, and I'd never had any medical issues. Always had normal smears, and I had a little bit of bleeding when I went to the loo. And I thought I had hemorrhoids, so I booked in to have a colonoscopy with a gastroenterology colleague, and I said to him, I just want to know that there's nothing more serious going on, and can you give me a ton of sedation because I really hate anything to do with my bottom. And when I woke up, he came in to tell me that I had a couple of tiny hemorrhoids and I should just use some over-the-counter creams, and I felt like I'd wasted his time. Over the next 4 months, I had a lot more bleeding. Things became really messy and I kind of had to change my sheets in the morning. I thought, damn, I'm going to have to do something about these hemorrhoids. So I booked in to see a colorectal surgeon, and he examined me and said, Mary, you haven't got hemorrhoids, you've got anal cancer. And my world kind of stopped. And so this was my first experience as a patient of not being listened to, not being examined adequately, not being appropriately diagnosed with anal cancer. And I was pretty shocked and angry by that. So that's my personal experience that I come to with this.
Next slide. So I think it's important to define and understand gaslighting is, what gaslighting is and how gaslighting appears in the healthcare field. So gaslighting, this term refers to a person of power psychologically manipulating another into questioning their own reality. And medical gaslighting can be defined as or describing feelings of being discounted or doubted by their physicians. I think this definition can be even broader and encompassing clinicians and healthcare staff in a variety of roles who treat patients. So understanding these definitions allows us to better define our experiences with healthcare. Medical gaslighting gained traction in social media in around 2022, and it first appeared in the medical literature in 2020. The first it appeared was in a patient account describing her symptoms and how they were discounted, and ultimately she was diagnosed with long-term COVID. Recently, there's been public awareness campaigns like Choose Wisely, a partnership between the American Board of Internal Medicine Foundation and specialty societies have developed clinical recommendations to help discourage unnecessary care and instead promote value-based care. Next slide. So how to spot gaslighting. Your provider, some of the things that could happen is your provider continually interrupts you and doesn't allow you to elaborate or doesn't appear to be an engaged listener. Your provider minimizes or downplays your symptoms, for example, questioning whether you have pain or, and then your provider refuses to discuss your symptoms. Your provider will not order key imaging or lab work to rule out or confirm a diagnosis, and you feel like your provider is being rude, condescending, and belittling. Your symptoms are blamed on mental illness, but you are not provided with a mental health referral or screened for such an illness. Next slide. So advocacy is really important. So for the clinician, goal is designating a patient advocate. And this is not to keep information from the patient. On the contrary, it is a priority. It's the priority to ensure the patient always remains informed. So patient-centered communication is key. Making sure the clinician's asking you questions and open-ended questions, being empathetic, having empathy, which can be expressed by naming the feeling, communicating, understanding, respect, and support, and exploring the patient's illness, experiences, and emotions. Exploring the emotional response is important and understanding the patient's perspective. And then for the patient or the patient advocate, that's asking questions, remaining informed, decision-making, problem-solving, having a positive attitude, clearly communicating your experiences and needs, taking notes, and push back when you have concerns. Next slide. I'm going to pass this to Mary.
Yeah, so in your first consultation, I'm going to describe my two first consultations because it kind of covers off the sort of differences that you might experience. So my first appointment with my oncologist, he was a really straight talking guy, and he said to me, look, you've got anal cancer, you need to have the Nigro regime, it's 50 years old. And he said, this is a brutal regime. And I really appreciated his honesty, and he gave me his number where I could contact him at any time of the day or night. And then I had my first consultation with my radiation oncologist. And this was a phone consult. And his opening comment to me was that anal cancer was often missed at colonoscopy. And I felt like he wasn't on my side. He wasn't advocating for me. He was defending the specialist who'd missed my anal cancer. He then went on to tell me that the radiation might cause a bit of soreness, maybe some red skin, and occasionally pain relief would be needed, and that I should try and work for the duration of my treatment because it would take my mind off things. He then spent 10 minutes telling me about his heart surgery and how because he'd gone through this, somehow that meant that he knew what it was like to be a patient. But at the time, I didn't want to know anything about his heart surgery. This was about me and my cancer. So I went through my chemo and radiation and had the typical patient experience, the one that you wouldn't put your dog through. I had an admission with neutropenic sepsis with an infected PICC line. I had horrible burns and really the worst pain I can remember experiencing. And I've had a couple of babies without pain relief. I thought I could do pain. I had to beg for analgesia after being told that gabapentin would be sufficient. I never met my radiation oncologist face to face because he felt his immune system was too vulnerable. He was always late for his phone consults, and on 2 occasions he just didn't call at all. He requested his assistant send photos of my burned perineum, an offer I politely declined. And I cannot remember being told about the long-term side effects of radiation. And at my last radiation appointment, his nurse gave me a set of pink dilators and said, you'll know what to do with these, presumably because I was a gynecologist. He never wrote any letters to my GP at my follow-up a month later after treatment. And at that point, I asked to be referred to someone else because I didn't want to continue to see this man for the next 5 years. I suggested to him that we just didn't click and I'd prefer a female. And I wasn't brave enough to voice these concerns, but I knew I needed someone else. So that was my 2 really contrasting experiences that I had at first consultation. And I just think it underpins the really importance of having your questions, having your support person with you, and going from there.
And I think that's kind of what you highlighted. It's highlighted in the first consult after diagnosis, just really making sure, like have the list of questions, understanding the diagnosis and staging before, before maybe going, at least having what some of the understanding a little bit of it, not maybe all the staging because it's kind of complicated, but to have an idea. And then general treatment options and tests, just to make sure that, they are ordering and they are looking at everything. And being aware of the side effects too, because sometimes they're most of the time I think they're downplayed. So, and that's really important to quality of life. and being aware, doing research on your oncologists and radio oncologists too. Do they have any experience dealing with anal cancer? Some people have never dealt with it, which is then really a big surprise. And it's fine to seek a second opinion. And being informed about the strategies to keep one healing during treatment and after is really important, having your support system.
Yeah.
So I think you highlighted some good points in the story and everything. So
Mary, can I ask you, what did the doctor ever offer you an alternative, or did you, rather than, or was it just, no, you need chemoradiation? Was there ever
Yeah,
any
it was,
discussion?
there was no alternative discussed.
Yeah,
It was
okay.
just, this is what
Do this.
this is what
Okay.
you need to do.
Thank you.
Yeah.
and then next slide. So this talks a little bit about the survivorship plan afterwards, and kind of looking at that and making, it's, even though you've, completed the chemo radiation, there's still, it's really important to be aware of what's after the chemo radiation, and you're not just done afterwards. You're going to have ongoing tests, and bone health and bowel health is important, pelvic floor. Your psychological health and sexual health are really important.
Yeah, so now I'm 2 years down the line, and I'm grateful to be well, and I have a fabulous radiation oncologist and colorectal surgeon who I get followed up with. But still, I think your anal cancer treatment permanently changes you. You lose a lot through this journey. I stopped working, so I lost my identity and my self-esteem. I lost the ability to eat what I liked and not think about my gut. I lost the freedom of being able to go out and not know where every loo is. And I lost my ability to enjoy sex. So what has being a patient taught me? Well, it's taught me how hard it is to be a patient, and how vulnerable and powerless you feel, and how important it is to have a doctor who cares about you. It's taught me that I want a doctor who tells me the truth about side effects and pain. I don't want it sugar-coated. And it's taught me that the doctor-patient relationship is crucially important, and both people in that partnership need to decide on the plan going forwards. I've learned the value of having a support person, having an advocate, having an extra pair of ears. I've learned about the necessity of being well prepared at my consultations, having my list of questions. I want a doctor who looks at me as a whole person. I want to be asked about my headspace. I want to be asked about my gut. I want to be asked about my pelvic floor. And I want to be asked about my pain. And I want to be asked about sex. I want to know about my follow-up in detail. I want to know what scans, when am I going to have them? How am I going to get my results? And when am I going to get my results? I want to be copied in on all my medical correspondence, because it's all about me. It's my information.
Mm.
I've also learned that it's okay to fire your doctor, and by all means tell them why, but you don't need to do that. I want to also acknowledge that I'm a really privileged person in this process. I am an educated white doctor, and I think that everyone I dealt with in my journey probably thought they were doing their best, but their best wasn't my best. And I think as anal cancer patients, we deserve the best to make this journey a wee bit easier. So if I can give you one bit of advice, it's speak up for yourselves and have an advocate and be incredibly well prepared. Thank you for listening to my journey.
No, and I think, like, you highlighted a thing that you want someone who's really holistic and all around. And a lot of times that's really hard to find, someone who really understands. I think it's not just like one-stop shop, so.
Yeah.
Yeah. Next slide. So supporting patients through procedures like HRA. So it's really important that the procedure's explained, that the person asks permission, and ask about negative boundary breaking experiences. So sometimes this could be triggering. And so it's really important that the provider knows that, and that should be asking that question. And then it's important for the provider to wait until the patient's ready. So are you ready? Are you okay? Are we okay starting? And you have control. So giving the control back. You can stop and pause anytime during a procedure, you know, if, hey, I need to pause, I need to stop, this is a little too much. Making sure that you and the patient are comfortable, so that's the provider and the patient. Making sure there's no pain or discomfort. You know, choose words wisely is really important. Don't use words like injection or here comes the pain. Wait for the anesthetic to work. That's for providers, so that you know that, like, it's not just, you want that pain medication to work. Music, video, Netflix, VAR glasses are really important. Distraction, talking, those are really helpful to, you know, to go through a procedure. Next slide. So support, and that's been mentioned before, how important that is through, you know, making, going through the healthcare system. So, you know, conversations in company. So making sure that you're having the honest conversation. If you're feeling you're not being heard, getting that addressed and making sure that you have someone with you. And making sure that you have, you know, your support group is with you to help you with your daily tasks through everything. And also having support organizations is important. Next slide. So I know we come to the end, and this is about empowerment. So the WHO defines empowerment as a process through which people gain greater control over decisions and actions in affecting their health. One thing is gaining knowledge and health literacy. So health literacy is the ability to understand health information and to use that information to make good decisions about health and medical care. Next is second opinions. So if it's fine to get a second opinion, and you shouldn't feel shame to get a second opinion if it's something that you're questioning about. And then self-efficacy, that is defined as an individual's belief that he or she has the capabilities to produce an effort or reach a certain goal. And embrace technology. So as we're moving, there's more technology out there. So to make sure we're sometimes communicating is through a portal, or making sure that we can ask questions through that, you know, and never stop asking questions, and having the ability to make appointments and reach your provider and everything. So that's really important, I think, to give us the empowerment for our healthcare. Next slide. And that's it. So thank you. Thank everyone.
Before we move on to the questions, so a couple of people are having trouble getting in. So Audra's going to stop sharing her screen for a minute so she can let the people who came in after we started. And then also, before we move on to the questions, after she lets them in and she shares her screen again, we will do our what we usually do in the beginning, and that is in memory. So this is in memory of Ron Rosness. He is a trailblazing LGBTQ activist and an HIV advocate, and he died in October 21st, 2023. And for those of you who didn't know him, apparently he was a power to be reckoned with. So we want to remember him. Okay, we can go back now to the questions. Feel free to put your questions in the chat. Thanks, Emily, for that. We were having a little trouble with internet and stuff like that, but I guess everybody understands that. And thank you, Mary, because I think it's even more shocking when you tell that story. I mean, you know, as a nurse, I feel like I had my moments, but as a physician, oh my goodness.
So Mary, tell us when you did finally tell the doctor that you were done, how did that go? Did you do it in person, or did
Well,
you
no, because
do
I've
it?
never met this guy, because it was during COVID,
Oh,
and he didn't feel like he wanted to face to face with anyone. So actually it was pretty easy to do it over the phone,
okay.
because I didn't need to face him. And I left it to the end of the consult, and I felt bad about doing it, because you know, he was recommended to me as being the radiation oncology guy from everyone, but it just was a relationship that absolutely did not work from me from the dot, you know, the very first time. And I just thought, I need to trust this guy for the next 5 years, and I didn't feel like he got me. So yeah, so I just said, look, I'm sorry, I think I need a female for my follow-up.
Mm.
Yeah.
Were you happy with the replacement?
Yeah, I was. I
Mhm.
was. Sadly, she no longer takes on any new anal cancer patients. She looks after other areas, which is a shame. But yeah, I've been really happy, but I'm quite a difficult patient, I think. You know, I'm quite demanding. I say what I want.
Yeah.
I think you need to be.
Yeah.
I agree.
I am not a good girl anymore. You know, I've got rid of that. I don't have to be a good patient. I'm never going to be friends with these people. I want to be well looked after.
Yeah. Yeah. Audrey, it's okay if people have questions and they want, because this is a pretty small group and they want to unmute. I see Helen. Did you have something you want to say, Helen?
Yes.
I
Yes.
thought so.
So I'm Helen Hutchings. I was diagnosed with stage 1 anal carcinoma in 2010. Had all the normal, I had surgery prior to knee grow, etc. Blah blah blah. I'm a member of IANS. I run an anal cancer support group. I'm an admin for the online Facebook groups, Anal Cancer Chat ad infinitum. Went to UK to do. I'm in Canada, so I went to the UK to do the final parts of the Cormac study. So I've done a huge amount of work voluntarily to help raise the aspects of, you know, short, medium, long-term effects post anal cancer treatment, and going from sort of diagnosis through treatment to the after effects. And I know that, I mean, we've got 500 and odd, Mary Jo, don't we? We've got 500 and odd anal cancer patients on our online forum. So we sort of live and breathe anal carcinoma, and we probably know way more than most physicians will ever know, because we just deal with more patients day in and day out. So I formerly was working in cellular pathology as a biomedical scientist. I'm a realtor now. My husband's a family physician, and when I was a biomedical scientist, I actually did my fellowship thesis on HPV and cervical carcinoma back in the day when PCR was just a word, and we we had one PCR machine in the UK. So there are a couple of things I wanted to comment on, and one of the things that I know that what I have to say a lot in our online peer support groups, we get lots of patients unhappy with their oncologist. And so one of the things I do say to them is oncologists, as a rule, are not renowned for bedside manner. They've gone in for that from an academic perspective, very, very much so. And so it's just one of the problems. That is not condoning their bedside manner. And I think it would be hugely beneficial if and I know medical schools are really, really trying to improve things, but it would be really, really beneficial if more medical schools were, you know, for all the medical students going through, were really, really given examples of how it would feel. I mean, if I was in front of a load of year 4 medical students right now and teaching a class, I'd say, now, some of you are going to, who'd like to volunteer to be a patient who we do an exam on today? And everyone who puts their hand up, I'd send to one side of the room, and the ones who didn't, I'm actually going to make be the patient who's examined. And then what they're going to realize is when these students descend on them one-on-one or whatever I make them do, it's a case of they're suddenly going to feel a vulnerability instead of being the more powerful being, which is the person in the room in front of the gowned and or semi-naked and or naked patient. I would do that on all things. And I'd also do great lectures on pain I know anal cancer patients, one of our biggest issues, we hear it's the same thing. It's pain management, non-recognition of pain symptom, non-talking about short, medium, long-term effects, etc. ad infinitum. What I would do to medical students, especially the radiation oncology medical students, I'd say, now guys, here's a Bunsen burner. Let's put one of our bacteriology pokey things in it. I said, now I want you to, how many of you would be willing to put that on your lip? None of them would. And I'd say, why would that be, do you think? And they'd say, wow, it would just be so painful. I said, okay, what are the two most sensitive parts of your body? Hands up, lips, anus, anal verge. Oh, interesting. So when a patient who's having radiation therapy on their anus is telling you that they are in pain, do you think their pain is a bit different from the person you're doing breast cancer radiation on? You know, do you think there may be a difference in pain level there? Yeah, bingo. So let's not start treating anal cancer patients' pain as if it's someone who's stubbed a finger or having radiation on this part of their blinking chest or something that's, you know, nowhere near. I also, and I know I'm saying a lot of things, but as you can tell, I'm a bit passionate about this. And I know my family physician husband has really changed his ways in his practice because of what I went through. And he's a lot more empathic and compassionate and tolerant and things like that. What we also have to remember, and every single doctor has to remember, is there are a lot of patients out there who do not have the capability, just because it's either intellectually or just because they've not had the opportunity to learn that intellectualism about anatomy and health things. And a lot of patients, they get overwhelmed. They've got white coat syndrome. So as we know, they all look on doctors as though they're on a fucking ivory tower, which most doctors aren't. They're very compassionate crew, most of them. So these kind of patients aren't the ones who are going to be like me. They're not going to be the ones going, oh, actually, here is my list of 20 questions. No, don't leave the room yet, because I haven't finished asking my questions. They're going to be the ones who sit and cower and just don't say anything. They're petrified. And doctors, again, this is another medical school issue that has to be addressed, that doctors have to be way more holistic. And it's a word that's been bantered around for decades. All the things we're talking about here aren't new. This has been going on since Adam was a child.
Yeah.
And attempts to make it better are happening, but not massively so. But when that doctor goes in that room and they see a patient who is keeping quiet, who is not taking notes, who's, even if they have a support, they probably brought the brinking spouse. The spouse is as scared as they bloody are. So they don't ask questions. And so the doctors just go on and on. And so it's for doctors and the medical team to understand and acknowledge and appreciate the fact that silence does not mean they've understood what you're saying. We also know that in stressful situations, maybe 40% of what we're saying to someone goes in. After that, you've said the word, you have cancer, you have some other horrendous issue going on, and their brain by that stage is like, whoa, and then don't take everything in. And that's known. It's like, so for me, it's more a case of there's so much education needed on both sides, and some patients are not going to be ever capable of being their own advocate, nor choosing someone to go in with them who is going to be their advocate. So that's just my commentary on it. And I mean, I've been really quite lucky in so much as the first time I met my radiation oncologist, he was a total bloody bravo egoist. And I just sat there with, I'd already written, as you can imagine, questions. And he tried to leave the room and I said, oh no. It took us 3 visits for me and him to understand the dynamics of both of us. And then he became brilliant. And I've been really lucky with my colorectal surgeon, who I'm 13, nearly 14 years out. I still see my colorectal surgeon annually, my gynecologist annually, and my new radiation oncologist. But my old radiation oncologist, we grew to just absolutely respect each other because we knew where both of us were coming from. And my new radiation oncologist is brilliant because he's really concentrating on long-term pelvic radiation. Skin
And
effects.
Helen, it sounds like you taught them things. And I think part of what I see happening with or I hope happens with these seminars is that people learn the language, and even if they perhaps their first visit doesn't go well, over time they know what kinds of things to ask and to expect. And when someone tells them, oh, you don't need that, or that's not important, that they can speak up. Because I do think that in this particular cancer, patients have a lot of influence to change what the care is like, but they need to take that power back. I mean, that's my feeling about this. And I certainly, if I were a physician and I was uncomfortable with my own place in the world, I probably would find someone like you completely threatening. And if I wasn't, and I was open to learning, I'd probably be really excited to talk to somebody like you.
Yeah.
That's my feeling about it. Does anybody else have questions or comments? Oh, before I don't want to forget this. In our newsletter, if you are a member of IANS, last newsletter there, Richard Goldman, who I think a lot of you know, wrote a wonderful article about what questions to ask your radiation oncologist. It was quite a long list, but it's definitely worth looking at. And this particular newsletter, which is coming out next week, Esther Hoven, I can never figure out how to say her name, but because she's Dutch. But anyway, she's a nurse practitioner who gave a wonderful talk at the conference in Puerto Rico, which Emily covered some of it, about how to physically touch patients and ask for permission for things, which kind of goes back to my initial story. That I think doctors, especially, there was a conversation at the educational committee meeting in Puerto Rico with the physicians there, and I was part of it, and they were talking about how can doctors do better interacting with their patients? How can they listen better? How can they approach them better? And so I think there is a place for this, and there's probably an openness to it. And I don't think we have a lot of physicians except our speakers in this group right now, but I think after they hear how wonderful this talk was, maybe some of them will listen, because I think there's things to learn. Peggy?
Yeah, we're talking, and somebody just asked the question down below, the after effects. I have been through hell for 33 years. 23 years telling me I had pre-cervical cancer, then it landed to anal cancer. Then in 2019, I stopped having the ability to defecate through my anus, and I went to 3 different rectal doctors. I live in the Tidewater area. And then I finally just gave up, and I like prep every night, still right now, prep every night as if I'm going to have a colonostomy in the morning. And it's really tiresome. It's hard. And then last November, I went to another rectal doctor. I'm so tired of them not listening to me. So I brought in my Barbie doll, and I had eraser things on it, and showing him that Barbie didn't have an anus either. And showing them my stomach. I know I have problems with my colon, and when I just can take that stuff, and then I start back into having constipation. He's trying to work with me now, although he says it's very unusual what I'm going through, and he doesn't think I'm healthy enough for a bag. He says, we got to get you kind of pre-healthy. He says, or it's not going to work. It's going to untangle, because I can't have other surgeries unless I can poop. I can't have back surgery. I can't have eye surgery. And all of these doctors, all of the time, they just ignore you. They said, well, you have a, this is the way you're going to be for the rest of your life. One gave me a card to go talk to a shrink, as if the shrink was going to help me to poop. But doctors, I have to give on the other side of the point. You always want them to listen to you, but they're not going through easy thing either. One after another, patient after patient after patient, death after death, those that live or die. I know that it has to be hard for them too, but you also want to be listened to.
Mm-hmm.
And then, I told him, I said, okay, everybody says that I got anal cancer because I wiped myself. I didn't know that if you went from pre-cervical to anal, why wouldn't it be called metastasizing in a way? And even before I was diagnosed with anal cancer, I went to 2 colon doctors who still didn't diagnose it. So it's hard all the way around. But when he checked me, he says, you have such severe radiation burns. I said, still? Yeah. So he says, we got to heal some of this up. But it's hard after being under this stress. And as that person asked the question down there, rectal prolapse, it's hard being under this much stress for 33 years. And even primary care, what are they supposed to do? They don't know all about it. They'll say, well, nobody knew that it was happening at the time. That says that you have to live like this. It's hard when you say how to talk to doctors. So that's why I brought my Barbie doll. And this time I just wanted him to laugh at when I pulled out the Barbie doll. And that was my only purpose really with the Barbie doll.
And right after that, he examined your feet and said, oh, your feet look normal, right?
No. Actually, he has quite a credentials behind him. It's the University of California at San Diego in '89, the AIDS crisis.
Right.
He went to the Mayo Clinic. He's dealt with a lot of that kind of stuff.
Do you feel like you've taught him anything?
Well, I had seen him before, right before the pandemic.
Mm-hmm.
And he said, well, we got to get you to lose some weight and get a little bit more healthier. I was going into pre-diabetic and this kind of stuff. But, I went to see other doctors in between. But finally, I went back to him because I knew sort of a feeling with him that he was someone that maybe not that day would listen to me as much as he was listening to me now.
Yeah.
So, but it's also hard on doctors,
Yeah, well, I understand that, but.
And when I told him about, he says, well, you can get anal cancer by wiping yourself. I said, where's the source? I've been on anal cancer and anal chat, and I've told people that's how it happened. They go, what's the source? And that's what I keep asking. Where is it written in medical?
We actually just did
I know that now. It's the cervix. It comes from the cervix.
There you go.
Okay.
Yeah.
But where is the source? Why aren't gynecologists?
The source is the vagina, cervix. That's where it comes from. So it really doesn't. Yes, I mean, men having sex with men are going to have anal cancer because that's where their penetration is. But women who have never had anal sex get it from their cervix. Okay, we know that now. It's a nice, warm, moist area, and HPV just loves that nice, warm spot. And whether you're wiping front to back, that we always were taught that by our mothers, and that's just a great way where that virus sets.
But that information needs to go out to gynecologists too, to be careful
absolutely
to watch for that.
Yes.
But where is the source? Where is it written in a medical journal?
Well,
Why people they don't believe me?
We actually, if you go back and look at was it our last seminar?
Yeah.
I go to the last seminar, and I mentioned that to him,
if you get a
and
chance
he mentioned it back.
Yeah.
But where is it written? Where is the documentation?
It's
There's
it's
the
in
doctor
that
from
particular article that we covered in that particular seminar.
I guess I missed the article.
It was written up. It was written up.
Yes.
Yeah, it was written
It's
up,
an
yeah.
Australian paper. So Peggy,
Right.
what we'll do is Mary Jo and I'll look for it, because
And we'll send it to you.
the wiping is just another potential way of
Correct.
HPV moving from the vaginal area to the anal area.
But
And
yes, for 23 years, I was treated for pre-cervical, freezing in the office, 3 in the hospital with laser. And then about 2010, everything started hitting the fan in a way. And then it was determined, I went to a emergency room, and there was this young physician in there. And he said, well, let me go look up your records. And all over my records, it was said what I might have, but nobody had told me.
So exactly this, that's what this seminar is about, is exactly what you're talking about.
You don't want doctors to think you're going insane or being over emotional. And
we don't care.
because I had to
We
go
don't
with my
care if they
brother
think
through,
that.
I had
We
to
just
go
want
through
us
my
to
brother
hear-
with AIDS. Yeah.
Yeah, we just want them to hear us. Emily, do you have some thoughts on this conversation?
Yeah, I think it's, it kind of all tails back that we want, it's hard to be heard and like being valued at moments in our, and also the healthcare system. I mean, that's a whole nother topic, I think, it in itself, and as we talked about, like even the system itself, I think is issues. So, it's why it's really frustrating for like providers and for patients, not feeling comfortable talking with that, but that's also just ingrained in the system, which is, I think, frustrating. So,
Yeah. Mary, did you want to say anything?
Just how difficult it is to be a patient and to be your own advocate, and how important it is to find your doctor who gets you and who listens to you, and how important it is to be the best advocate that you can, and to doctor shop so you find someone who meets your needs.
And I think that's always a scary term to like doctor shop, like, oh, you don't want to do that. But I think sometimes you want to do the research and learn, like, is this someone who understands or their background and what they're doing? Because I think it, that I think has, some people have like a negative term with like doctor shopping, but it's not what you want to find, the person that fits you. And that's hard.
Well, it's hard. And in between trying to find all that out, now I couldn't have my surgery for macular hole. Now I'm 60% blind. I'm in a wheelchair because of my left leg and the way that it doesn't work. And, it's just, but he seems to be listening to you. So today I had my first home care person that came in and gave me physical therapy. So and my new primary care is working with him. So she says, you must have some VIP. We're getting things to roll now. She goes, now I understand. But it took her to listen to another doctor.
Yeah.
And it's hard on the primary cares because they don't really know either.
They don't.
Well, that's what we're trying to.
And you see those commercials out there, HPV, and they look so warm and cozy. Somebody needs to put a shocking picture out there like they do for the smoking people, smoking through their whatever, their neck or whatnot. Somebody needs to do some sort of other HPV. Oh, it could be cut earth. Talk to your parents and they lay on the bed. Maybe they should see the end result of what happened. Somebody needs to get with that company, Geracell, whatever it is, and put out some really horrid commercials.
Yeah.
Mary Jo,
Yes.
can I just speak to Feline? Is asking some.
Yes, I was trying to go ahead and.
Yeah. So Feline, there are several really, really brilliant anal cancer support groups online in many countries in the world. I don't know which country you're in, but it doesn't matter because most of them are international anyway.
In the United States.
Okay, so the Anal Cancer Foundation in the United States is one. The Macmillan Nurses, Bumlander in the UK is another brilliant one. We're on Facebook for the ones we do and all the rest of it. So as far as you know, you were talking about rectal prolapse. Well, that's your colorectal surgeon's issue. So you would actually go back to your colorectal surgeon if indeed you had one. And even if you don't have one, a rectal prolapse is now in the realms of colorectal surgeon. So you go to your primary physician, you tell them that you have this strange sensation anally, rectally. They'll most probably refer you to a colorectal surgeon, and that's that. The neuropathies are something that many, many patients deal with. It's not just anal cancer patients, because it depends on what kind of chemotherapy you're given as to whether you're going to get any of the neuropathies. So your primary care physician, again, they will attempt to help you with that. That's quite a specialized thing to talk about the neuropathies. But what I'm saying is there are resources online, bona fide resources, RILSP. I'm not quite sure what that is, Feline. So, but there are many, many good resources online if you do search for them. So don't, you're not alone. You're not going to be the first person who's had the kind of effects you've had. Oh, radiation-induced lumbosacral plexopathies.
Oh, plexopathies. Okay.
Well-known issue, and the Cormac study it is all outlined, and it all went out everywhere, from the Cormac studies to the Anchor studies to you name it. Doctors should be aware. And so I would start with your primary care physician. They're not going to have the answers, but hopefully your primary care physician is a lovely, caring, vocational physician who is going to say, you know what, I don't know the answer to this, but I'm going to try and find out for you. And I'm going to refer you to the people who I believe will be able to help you with the issues that you're having. And every single short, medium, and long-term effect of pelvic radiation has been studied, logged, written about, and the ways of trying to deal with some of those effects has also been logged, written about. So in essence, unfortunately, it's sometimes a case of, you know what, not every single most doctors are exhausted and stressed, and and it's really hard to read every single paper that comes out. So just speak to your primary care physician and see what they can do for you, because honestly, the vast majority of doctors are so vocational and they really, really want to help you. It's not about them, it's about you. And so I would start there and look online.
Mary, do you want to say something about your group?
Oh, yeah. So in New Zealand, I've started up a support group called Anal Cancer Support Services, Aotearoa. So we offer a peer-to-peer support program, an informative website, and a closed Facebook group. And the Australians didn't have any things, so they've asked to join my Facebook group, and I've said that's fine. So that's because when I was going through treatment, all I wanted to do was to be able to connect with someone else who'd been through this, and so that's why I've started up this, and it's been a really fulfilling thing to do.
Mm-hmm. One of the things you brought up, and I think most of us who have been through this, is that we're not told ahead of time what some of the long-term effects are going to be. And I remember having a conversation with my radiation oncologist, who was a really nice guy. And I said, if I had known what was going to happen to me, I might have just had a colostomy. And he looked at me in horror and said, really? And I said, I would have liked to have known the whole story. So I think many of us don't know the whole story, but I think, or didn't know the whole story and made decisions, some of them good, some of them not so good. But I do think being able to ask those hard questions of your physicians, and they might not be able to answer you. That's part of it. And if they can't, then we can add to their knowledge by telling them what's happened to us, what our lives are like. When we did the patient panel at the Puerto Rico meeting, that's a favorite part of the meeting, because everyone listens to what the patient's stories are. And they're all moved by it because no one holds back when they tell their stories. And that is part of what we need to do, is to tell our stories, especially to everyone, but to our physicians, so they know that we can't eat, we can't poop, we can't have sex, we can't, all those things that we've lost. We're getting close to the end. So
I do want to ask one more question, because Helen's seen it in some of the chat room groups. And I know me, myself, but it's hard because my mother and grandmother had vascular problems. A lot of women are coming up with vascular problems.
mhm.
And it's kind of found out in the end. And I think that this area needs to be researched a little bit more. Why all of this vascular stuff?
Mhm.
I don't think it's a case of it needs researching more. I think it's a known complication of radiation. It's a known complication, especially pelvic radiation.
Yes.
It's a case of, I think sometimes all oncologists have to step a very difficult role. It's like every obstetrician sitting there with their newly pregnant, first time pregnant mother patient and saying, okay, now I'm going to tell you all the pros and the cons. And there's a lot of cons of childbirth. And so if you told them the maternal death rate in such and such a country is X, the risk of caused strangulation is Y, and most of them will just go, oh. And I think it's a fine line you have to walk between how much do you do? I mean, it can be really scary when you tell everyone what the really downsides are.
But the vascular part seems to come many, many years later.
Well, that's a known entity. It's known.
People aren't going to their oncologist anymore, their radiologist.
That's where the primary care physicians, unfortunately, become the gatekeepers. And for a lot of primary care physicians, you know what? They are very skilled. I'm married to one, but it's really hard to know everything about everything. And this is where I'm going back to, hopefully you have a primary care physician who is vocational and empathic, who's going to say, I don't know the answer to this, but I am going to make damn sure we find out the answer together.
And holding them accountable to answer you is a really important part of your responsibility as a patient. You can't expect, I always think they go on with their lives and we go home and we live this life, and they're not thinking about us every minute, and that's okay. They shouldn't be, but we need, when we're in there dealing with what we're dealing with, to help them to focus on what our issues are. We're down to our last minus minute. So I'm just wondering if Emily or Mary or Linda have anything more to say. And I just want you to know that our next seminar I think in March, is going to be on pain, which is another huge thing that people don't want to talk about. And I've got a couple of wonderful speakers, but as we wrap up, and thank you, Helen, too. Anybody, Emily, thank you for your lovely slides, but anybody want to say any last thing, except you go, girl?
Don't be afraid to fire your healthcare provider and find another one.
I just did.
Yeah.
And Mary, do you have any last words?
Yes, I know. I like that. You go, girl.
And Emily?
Well, I just wanted to thank everyone for their stories, and the discussion was really interesting. And I always find that really fascinating. And, I know it's really hard, but just keep, trying to speak up. And even if it's uncomfortable, and it's something that's not always ingrained in us. So, I think it's a skill we have to learn, and it's really hard. So
Yeah, and as women, I think
Yeah.
particularly, yeah. So thank you, Audra, too, for
Mhm.
helping us through all this. And happy holidays, and we hope to see everybody, I believe, in March.